Good to see you all back. It's good to be face to face. Everyone likes a conversation. Right, welcome back everyone. So we're into the next session. Apologies, I'm still here, so for those of you who want to see someone different. But we've got a really good session. It builds on some of the work and information we heard earlier through the work at Manchester and in Cumbria around the use of important financial information, and also how that then changes the way an integrated care system works. So this is a case study of one particular integrated care system in North East London. And I'm joined on stage by Carolyn, Botfield, and my colleague who works with me, Gerald, and
Enuezie.
Yeah, so we work together in Barts. So we're going to talk about the way we use information, but also what difference it makes to the population and some of the insights it brings. So please, I'm looking for questions either in person or on Slido, and we'll kick off with an introduction from Carolyn, and then we'll hand over to Gerald. So over to you, Carolyn.
Thank you. So I'm Carolyn Botfield. I'm probably one of the only non-finance people here today, I think, but it's been really, really interesting, so thank you for letting me come. So I'm the Director of System Transformation and Infrastructure, which is both digital and physical, for the North East London Integrated Care Board. So just a bit of a background about North East London. So we've got a very unique population and a lot of challenges that presents a lot of opportunities for us if we understand that data and we can use that data evidence-based. So we've got a very rich, diverse population in North East London, some of the most diverse places in the country, young, very densely populated and growing very rapidly. We've got high levels of deprivation, with nearly a quarter of North East London people living in one of the most deprived 20% of the areas in England. Many children growing up in very low-income households, and up to a quarter in several of our places. Very stark health inequalities, and our population has some of the worst health outcomes for the rest of the country across many of the key indicators. We also are the fastest growing place in the UK. So our population is set to grow by over 360,000 people in the next 20 years. So that growth rate is 1.5 times higher than the rest of London and 4 times higher than the rest of England. So if that was a London borough of its own, it would be London's third largest, just in the growth. And 77% of that is concentrated in just 5 areas, which are shown on the map. Those are the GLA housing opportunity areas. So we have to act, we have to be dynamic, we have to innovate, because otherwise we've got a lot of people going to be putting a lot more pressure on our services. So what this means for us as a system, we've got a massive opportunity there to meet that challenge, but we have to have greater collaboration and alignment between our partners, like Barts. So we need to make sure that we're addressing all of our immediate pressures, and we're looking at that longer term horizon. So I'll hand over to Gerald in a minute to talk about the Barts costing model, and at the end I'll tell you more about our 20-year forecasting model, where we're pulling all of the data together to look at how do we start to do some of that stuff that Julian mentioned this morning around projecting forward into the future and not just planning a sort of 12-month cycle. So problem statement for us, as the ICS, we all face a shared challenge that requires that collaborative response. So we expect to have the fastest population growth in the country, and we haven't yet quantified what that impact on our population health needs, our capital, our workforce, our finances need to be. And that's the purpose of some of the modelling and the forecasting that we're looking to do, and we've already started doing for the last year. So we have to go further as that developing ICS system, and we have to realise that collaboration, new ways of working, and utilise our data and our BI, which we haven't been using as well as we could do. And some of the stuff we've heard today about the bots, I'm already thinking about how we can integrate some of that stuff now. So I'm going to hand over to Gerald to talk in detail about the Barts tool.
Yeah, sure. Hi. Good afternoon. My name is Gerald Enuezie. I'm the Assistant Director of Costing at Barts. So the starting position for us was kind of developing a 5-year costing strategy plan. And the 5-year costing strategy plan was by 2026 to be the best in class, to have the best costing team and the best costing tool in the NHS. And they actually drew on, normally when we talk about costing, we talk about SLR data. And I remember when I came back to Barts, the first thing Hardev said was, I did not want it box standard SLR data. I want somebody to tell me a story. And at the same time, actually, I just finished my doctorate on population health. And actually, so I drew on the experience of writing a thesis on population health and Hardev's vision, which is basically he wants a system that told him a story. And actually, and also drawing on the things that Carolyn has talked about in terms of looking at population demographics within the North East London area. So before we go into the reports, one of the things is, what is the value of these reports? For us, it's looking at health inequalities, ethnicity, deprivation, clinical variation, the distance people travel for the care, the impact, for example, of the Elizabeth line in London as well, and what are the drivers of cost? And actually, for us personally, it's about knowing our patients. What does it cost to treat a patient in North East London, and what drives that cost? Now, if you look at our data, now looking at this one from a trust position, is we've got 4 hospitals within Barts Health. Newham is an area that is very, very poor, very diverse population with a big Bengali population. Whipps Cross, white, middle class, elderly. Royal London, high levels of poverty and great levels of affluence because of the near Liverpool Street, and St. Barts is in the centre of London, where we're quite specialist. But looking at this data, the first thing that is you look at the clinical variation in terms of the length of stay, the cost of treating the patients, medically fit to be discharged. But this doesn't actually tell you what is driving the cost. What we did was, one of our clinicians actually, Professor Fimba, who is our chair of our steering committee, actually came up, said to us is, increasingly within these cancer clinics, a lot of the patients he was seeing in these cancer clinics had diabetes. Can we bring in the diabetes flag? And so we brought in diabetes flag into our data, into our patient level data. And actually we split the data now between people that have got diabetes and not diabetes. And you can see the stark difference between people that have got diabetes and not got diabetes in terms of length of stay, medically fit to be discharged, their readmission rates, because obviously we are readmission rates, we don't get paid, we get paid non-elective care. And also the cost of the ward cost and the theatre cost of treating these patients, and the distance that the population travels. And actually, if you look at the size of the population, the people that have got diabetes are quite small. But if you look at it, they drive a majority of the cost. If you look at the top 10 service lines, you could see the medical oncology and hemato-oncology, which are the cancer special service lines. And you could see that what Fimba was saying in terms of the patients with diabetes. Also, one thing that in our data, we didn't bring in the slide, but if you look at the maternity, 70% of all emergency cesareans at Barts Health relates to the Bengali community, and vast majority of them have got pregnancy diabetes. So what we've also done is broken this information down into different ethnic groups. And now you can see that the medically fit to be discharged within the Asian population is lower than other groups. And one of the primary drivers, actually there are 2 primary drivers for it. One, the Asian population tends to live in multi-generational households compared to the black or the white communities. And as such, they'll have a lower medically fit to be discharged. And the second thing is they are younger. There's a younger population. If you look at the age profile, so we've brought in the 2 top ethnic groups. In terms of the patients that have got diabetes, you can see that within the white community, it's an older population. And when we come to the Asian community in the future, you'll see, in a minute, you will see the different population groups in there, the age diversity. One thing I must say is that in our data, we've layered in the patient-level data to the ONS data on population, as well as the data from the Ministry of Communities on deprivation. So we could look at, by postcode, every patient that has been seen at Barts, in terms of the deprivation, ethnicity, age, profile, and whatever profile that is within our power system. So 1 is the most deprived, 10 is the most affluent, and you can see within the white British community, especially people with diabetes, is the 3 2s and 4s. One thing we've also done within our data is that we've layered in all our data on a map of the UK, and everywhere in green represents a patient that's been at Barts Health, and everywhere in the shaded colors shows where the prevalence of diabetes are. You can see in the northern half of Whipps Cross, Newham area, and the Royal London around the Whitechapel area. If you look at the Bengali population, they tend to be younger than the white population that we've seen. And the question is why? What is driving that? And that is the work that we need to do as we move forward as well. If you look at the deprivation in decile for the Bengali population, within the white British population was 3 2s and 4s, but within the Bengali population is 2 3s and 4s, so they're more deprived than the white population. And you can see also that there's a variation in terms of the medically fit to be discharged and the rate of readmissions. If you look at the, in terms of the diabetes for the Asian population, I've used the whole Asian population, they seem to be concentrated along the Whitechapel area. And we were doing a presentation to one of our clinicians, and the question was why? And one of his comments, I don't know whether it was a joke or not, was that around the Whitechapel area is full of too many chicken shops and fast food restaurants. And we're now actually doing some work in terms of bringing in the prevalence of fast food restaurants by postcode and to see whether that makes a difference or not. And that's the work that we're going to be doing in the very near future. The key messages are, everything here has been done with our clinicians in mind. We've got a costing steering committee chaired by one of our top clinicians. Clinical services drive the cost. We in finance don't drive the cost, and we need to work with our clinicians. Equality is pivotal. Anything we do, we need to make sure that people have equal access to healthcare. And we need to use this data to change the culture of what drives cost and how we transform our services. Carolyn.
Thank you. So you can see the amazing applications, so many layers and so many multiple ways we could use that. And I've only recently discovered Gerald and team a few months ago, but what I've been doing since October 2021 was trying to get the system to build more of a forecasting tool. So what we've done is, for the last year, my BI guys have been trying to build me a 20-year forecasting model. So we know with the GLA housing targets and the information coming out of the councils on the population growth projections, but also our non-demographic growth and our demographic growth, when you add the two together, how sick our people are, how many obese children we have, what that might mean for diabetes and CKD and then dialysis. We've layered that all up. We've got all of the acute data in there so far, and we're just moving on to add in the mental health, community and primary care data, so we have a whole system view. And what I wanted, because my role was estates at the time, I wanted to be able to look forwards to know how much infrastructure we needed, both physically and digitally, because it takes a long time to get capital, it takes a long time to get these things built or delivered, and they need to last 60 plus years. So it's really hard with a 12-month planning cycle to get any kind of forward look. So this will give us a forecasting tool that allows us to run lots of different scenarios, because the other thing we have a tendency to do in the NHS is fixate upon one answer, and then it's really difficult when you've written a business case that says there's only one thing and there's no plan B, to change that or be flexible in any way when things like COVID hit us. So what we are doing, and what Gerald's team give us, is that baseline look back of 4 or 5 years worth of data that allows us to predict forward much better. So for the next year, we'll be combining the two things together and then building, as I said, all of the other data sets to allow us to move forward so that we can join this all up. And we've spent the last 6 months with our finance team working through this year's operating plan system and process to look at how do we have this model driving next year's. So ultimately what I'd love is that the model and the tool that we've built drives the plan that we have, not an exercise in filling out spreadsheets every year, and automates it, as we talked about this morning. All of that automation looks at all of our joint forward plan, all of our different capital prioritisation strategies that we're looking at about where we spend, what gives us the biggest impact. And in my new role where I'm looking at transformation now, how do we measure impact? So that evaluation of value this morning was really struck a chord with me, and I'll be following that one up because we have to be able to see where these transformation programs are making an impact. As I said at the beginning, we've got some of the biggest challenges, so we're going to have to act fast, and we're going to have to be able to measure what makes the impact on our demand. And if it doesn't, we need to change, pivot, do something different. So this is just a screenshot of what it currently looks like. It's built in Power BI, which we've talked about a lot today, and we're already delivering, information, data, and modelling for the system at the moment. So yes, we will continue to evolve. We will continue to evolve as a system, but also as a programme in terms of looking at our data and working together and collaborating. But that's everything.
Thank you very much, Carolyn and Gerald, for that. So just listening to that presentation, there was quite a bit in there which focused around the relationship with clinicians and how important that is. You also talked about the predictive nature, and I think it links well with the AI agenda and the benefits of that, and we'll talk a bit more about that as well. The data itself that we looked at there, can be cut, correct me if I'm wrong, Gerald, by all sorts of characteristics, and you've got it for primary care as well?
Yeah, so the plan moving forward is that we're going to, first of all, using the Barts platform to get BHRUT and Hamilton on the Barts platform, and then go to the local authority and the mental health. That's the plan. So
it'll be all system analysis of service usage, cut by characteristics. That should help planning moving forward, not just for health, but also our system partners. So that's the aim, is an all-encompassed approach. And I know Gerald probably wouldn't want me to say this, but I know NHS England, I've been in contact with you about potentially looking at this across the country as a way forward, but I know you're going around different various forums showcasing some of this.
Thanks to you.
Yes, and just for those who are interested, we have patented some of this as well, so it does come at a price. But the main point is that we're trying to use technology and data to help inform future models and predictions, and the clinicians are bought in on this. And so some of the questions we normally get are, is the data right? Or that's not really applicable here, but this is actual data. It shows you at a street level what's happening with patients, how much it's costing, and what services they're using. So it is quite granular in that level, and the clinicians through the steering committee are very well engaged and bought into this. So that's my little sort of context piece there. If it's okay, we're just going to open it up for questions. So please raise your hand if you have any questions. I'll start off by taking a question on Slido here, which is for Gerald. There are two main types of diabetes, type 1, type 2. Are you able to split it down, and what does that do to your cost driver?
For us, I think type 1 and type 2 diabetes is related to the HRGs. We're going by diagnosis. I think one of the things that in finance, we always talk about is HRGs. When you talk to a clinician about HRGs, they just go blank. It doesn't make sense to them. They actually go down by the diagnosis codes. Yes, we go cut by type 1 or type 2, but the main thing is diagnosis, and they've been diagnosed with diabetes within it's not the primary diagnosis, but within the spectrum of diagnosis. So yes, we go cut by type 1 or type 2, which is the HRG, but then that's a higher level. We're going down for the granular level, which is basically diagnosis, in terms of diagnosis.
Thank you for that. There's a question just here towards the front, and then there's one there.
Hi, I'm Jane Hazel-Greer. I'm the Finance Director of an ICB at Humber in North Yorkshire. But in a prior life, I was at a CCG CFO, in Bradford City. So in terms of the diabetes, we did a campaign called Bradford Beating Diabetes, which was about, so the CCG was that the two Bradford CCGs are like an outer donut and an inner donut, and the inner donut was predominantly Southeast Asian population with massive diabetes problems. So we did all the similar work in terms of joining the primary and secondary care data, and launched sort of like a public health campaign, which is called Bradford Beating Diabetes. So there's something, isn't there, about out in the data, but then it's about what do you do with it. So this was about a massive, so the town hall was lit, the colour was lit purple, we had the local authority, there was lots of things in terms of cooking lessons, it's about, and we did all case finding of patients with pre-diabetic conditions, so that they weren't diabetic, but from a primary care record it was pre-diabetes. So it just feels to me just as a thing that we're all doing and coming up with great ideas, but there's lots of things that potentially we've already done that might make a difference. And I suppose it's just a comment really about under one NHS finance. How do we ever take some of these things and industrialise these things that we're doing? Because it's great to see this analysis, and it's fantastic, isn't it? And getting your clinicians really involved. But the next thing is the so what. And for us, what we were trying to do is have a pathway that was joined between getting all the diabetic budgets together in terms of amputation at one end to prescribing at the other, creating a programme budget and trying to say, what do we do with that resource to treat diabetes differently? But I don't know, I left after that, so I don't know what they did actually, but that's what we're doing. But it's just an observation, really. Thank you. Really, really good.
Yeah, no, it's a really, really good point. And Gerald, how is this connected to the NHS Innovation Forum?
Pardon my ignorance. I'm not quite sure about the NHS Innovation Forum, but what we've been doing is that this tool was built in-house, and I think the message for us is how do we now take it out to the outside Barts Health, and where we showcased it to for example, the ICS and ICB, who didn't know about it for a few weeks ago. It's been great, and I think for us moving forward, it's all about using the Barts platform and sharing it with our colleagues and working with our colleagues and our clinicians to start changing the culture. And I think that is the main thing, that's the main goal. And also at the same time, I know Virginia has invited me to the HFMA conference in October, and so we're going to showcase this as well. And we will offer to help our colleagues as well if we could run a training session in terms of what we've done and sharing knowledge. And I think it would be good for us to share the knowledge of what we've done with our colleagues within finance, basically.
Yeah. So I know it's also on the Innovation Forum, and I would also emphasize the fact that your question about so what is the one thing that the Barts board and everyone else has been asking, so what are you going to do about this? How is it going to change things? And it ranges from, if you look at the heat maps, they go down to street level. That helps you design services differently. So we should, in theory, be able to predict the winter demand coming up based on previous usage by our population. And it does raise questions about the way some of the services, primary, acute, community services, are configured and serving that population. So I think we've got the tools to actually make a difference. The question is, can we make that happen with our clinicians and drive that change that's needed at a system level? So that's the next stage, is really making those changes. And I would agree, we need to learn from the past as well to make sure these initiatives are connected up as well.
Can I add to that?
Sorry, Carolyn.
Sorry, just to add to that again, for me, the so what is also how we help plan with our colleagues. So we've got effectively 5 new towns being built in North East London, either on completely new brownfield sites, like Barking Riverside, which is being built on an old power station. That's going to be a 60,000 person new town. So thinking about how we deliver health and well-being, how do we keep that population more healthy, so it doesn't just increase our demand on all of our health and care services, but our councils themselves, our public health departments have been talking about fast food restaurants and the proximity of those for so long. But what we can do now is link those data sets together and say, we soon be able to see the impact on our services and our hospitals of the proximity of having those things. So it underlines for our health and wellbeing boards and our health and wellbeing strategies that when the councils are looking to put in planning systems and planning laws that say, we can't have any more fast food restaurants in this area, or we need to reduce them, then it's about how we help all of our system work together and how we actually start building some of these new towns by using some of this data. So it's really, I think there's a really great so what.
Yeah. So I know we've got a question just there, but I'll come to you in a second. I just want to ask this question for you, Carolyn, on Slido, which is, how are you engaging with your community that's growing exceptionally about the future of healthcare, particularly as some communities don't trust us as COVID showed?
Yes, so it's a great question. We have just launched something called the Big Conversation, which is just starting where we're reaching out into communities to do that and have a lot of those conversations with them about co-production and listening to them and how they want things to work. I ran the vaccine programme for North East London for a year during COVID, and again, we had to take that out. We had very reluctant populations, and we had to go out and speak to them. We had to take the vaccine to them, and that's where we need to be taking all of ours roles in primary care, some of our community services. I keep saying to the GPs when I speak to, go back to the places we took that vaccine, go back and have those conversations with people. And when you start talking to people, it opens up so much. You know, we've been having a conversation about pulling dialysis out of the hospital. So one of the Barts dialysis services is moving it into one of our new community buildings. And by speaking to the clinicians initially, we noted that you actually had a captive audience where someone's having dialysis. So, you know, maybe they could do health checks or they could do education and prevention because those people are going to be there for hours. And actually talking to the ops directors, we started saying, that means you don't need to have consult examination rooms alongside because you can do all of that stuff while they're sitting in the chair. But then we went to the patients and said to them, does this sound like a good idea? And they said, yes, please don't make us come back several times in a week. But actually, more importantly, could you entertain us, please? Could we have book clubs and art clubs? And so actually what we've come up with an offer there where of the bays that we're putting in, which I think is 23, about a third of them will be quiet, so you can book a quiet bay, and then there'll be a roster of activities on the others where it might be diabetes education stuff, it might be book clubs or art clubs or, you know, something going on to keep you entertained. And that, again, was about co-producing that with the people accessing those services now.
Great. Good. Question over there, please.
Paul Brown, CFO at Staffs and Stoke, ICB. Just two questions, if I may, while I've got the mic. The first was just about whether you have or decided not to use the shared care record, because for me, the future has to be the whole pathway for a patient. You mentioned primary care in the Barts platform, so I didn't quite understand how that fitted in with the shared care record. And the second question was probably to Carolyn, but in terms of estates, that's one of the things on my to-do list, which is rather problematic, is how do we cope with, as you said, the growing population. But we don't seem to really have grasped the opportunity of COVID when we work very differently. We seem to have exactly the same, what we do, the same mistakes as we did before. Yeah. I was wondering whether you've got plans to do anything about that, using digital.
Yeah.
So, Gerald, do you want to take the shared care record?
Well, in terms of using the Barts platform, I think we need to go through the whole regulatory framework, and also from a technical perspective, we need to make sure that the data aligns properly, and it's how we align the data. And I think that is going to be the next challenge between primary care and secondary care in terms of realigning the data. But it shouldn't be. I don't think it will be technically challenging. I think it's something that we can do, but I think it's just the initial conversation of what do people actually want. Now, we've designed it from a Barts Health perspective, but actually, what does the ICB want? What does the Barts board want? So I think it's all about getting people, the conversation going, and once we know what people want, then the rest of it is pretty straightforward from a technical perspective.
We're quite lucky in London as well, because we've done a lot of work around the discovery data set, so we've got quite a lot of the primary care data already pulled together in a form with that. So we've got other ways of pulling that data now already. To the estates question, it's very hard. It's a very challenging environment. Costs and inflation are spiralling. There isn't the capital out there. I mentioned that we're a very challenged ICS, so we've been historically very underfunded. So we have about 25% of London's population, but only 10% of the capital each year. So we've got things like Whips Cross on the new hospital programme, which is amazing. The building I referenced earlier with the dialysis is the St George's Health and Wellbeing Development. That will be a completely new integrated model of care. It's 4,500 square metres of space, but it's going to have primary care at scale, out of hospital coming out of Queen's Hospital, dialysis coming out of hospital, an early diagnosis cancer centre, a CDC, all of our community mental health and social care. So the way that we're looking at trying to innovate our buildings, starting with this one as a pilot, but I'm hoping to spread out over our existing estate, particularly the primary and community, is looking at things from a different perspective. So if you look at some of the best practice globally, there's a women's and children's centre in Canada who've just flipped the operating model on its head. So they're not service booked rooms, they're patient booked rooms. So a patient comes and is booked in a room for a session and the clinicians have to come to them. And it's much more efficient staff-wise, it's much more efficient estates-wise, and the patient outcomes are much greater. So this particular area of Havering is very old, and we had a cohort when we were at the business case of 22 people who were accessing care or contact points with health and social care more than 10 times a week. Thinking about the outcomes that we could deliver for those people if they came in once, and we revolutionised the way that we designed one-stop shops in the sort of early 2000s, where we put everything under one roof, but we didn't actually make it so that the patient didn't have to come 10 times to the same building that week. They come once, they get one care package. So that's due to be open this time next year, and we're just working through the pathway redesign that allows us to do that, but also using technology to have a really sophisticated building scheduling system that allows you to flow that type of activity differently through each room every day.
Great, good question. So just a question on Slido here, which is, whilst you're looking at fast food facilities, is it possible to look at the positive health clubs like gyms?
Yeah, so in terms of looking at fast food, whatever data is on the .gov.uk website, we would use. And the thing for us is, do we have this data by postcode that we could actually layer everything in by postcode? Yes, we could look into that as well. And I think one thing we need to be mindful of is that the more data we bring in, the more it expands our servers. And I'm sure Hardev would not like me to say that when our BIU's team says to him, well, we need £1 million for a new server. So we need to be mindful of that in terms of there is a cost to it, but also we need to make sure that the platform works as quickly as possible. So if we layer it in, we don't want to make it too complicated, too cumbersome, that it becomes unwieldy and unusable.
Okay. Any other questions from the floor? We've got another question on Slido here for you, Carolyn, which is, are you using AI machines learning in your predictive 20-year forecast model?
No, not yet. What we've done is our BI guys have actually done a 4-month literature review, which we're hoping to get academic partners to then ratify and publish as a proper report around the predictive multipliers that you'd expect. So if somebody has, somebody's obese, they might end up with diabetes and then CKD and then need dialysis. So we did about 4 months worth of work with partners around looking at those multipliers that people already put in things like PBR and some of the predictors that we used. So we've done quite a lot of work there, but I'd really like to get us to the point where we could get a bit of funding together, we could start to look at the AI, the bots and some of the stuff this morning would really, really help to be able to enhance that.
Good. Simon.
Thanks, really, really interesting. Couple of questions from me. So, one, your 20-year growth model, that's a huge increase in population.
Yep.
And really, you're planning it out, you're thinking about it, which is really positive. I'm wondering, Hardev, how are you going to influence the allocation formula? Because, I think it's really
my favourite subject.
Yeah, so if you're having conversations about that, that'd be good to know. And then I'm just interested, who's going to live in all that? So what's the demographic that you're going to get, and how are you predicting that? Yeah. So
in terms of the demographic, it's often predicted by the public health teams. I would say one of the issues that we have around that is that the council's often very ambitious. So they always expect them to be rich young commuters. And one of the problems we have is they're not rich young commuters. So with Barking Riverside, which was supposed to be a 30,000 person new town, but they're going to double the housing output they've decided this year. So they're just redoing the planning, so it'll be 60,000 people. And that's 15-storey tower blocks along the riverfront that they're saying they can stack to 33 stories in the same amount of time. They've already built the stack, so they'll just go higher. The first phase of that was actually built 10 years ago, and the rest got delayed because of the Crossrail coming in. So for 10 years, we've got 10 years worth of data now. So we've been looking at that data to see who are those people, who moved in. That's actually an extension of the already existing population. There was no station there, so again, difficult for rich young commuters to move there. The station's now open, so what we're keeping an eye on is, does the profile start to change for the later phases? But I mean, the first phase, our feedback from the frontline GPs and stuff was that street crime, knife crime, gang crime was actually rife, and that was one of the biggest problems that some of the residents there faced. And it was just an extension of the existing population. So it's really hard, and the data is so important because some of the predictors are so ambitious and optimistic. It's often not what it ends up in reality. And it's exactly the same with Stratford. You know, if you actually think about that, the Olympic Park, that's a new town. It's still being built now. You know, they're still adding more tower blocks to that. But if you walk around it, that's where our office is, you see large families living in flats. Like, we know the housing mix isn't right, and so it's helping partners to be able to review that data, review the impact on health and care, so that hopefully we can influence some of the planning going forwards.
Final question from Tim, and just to say something, I will be pestering about allocations once I've talked about the dire straits of the capital allocations. That's next on my list. Sorry, Tim.
Get that one sorted first, Hardev.
Yes.
Hi, Tim Jaggard. I'm at UCLH. Really, really good. My background's in costing, so I'm always quite excited to see practical examples of it being used. My question is about how much work you've done to join up those data sets again, because my sort of hypothesis, and you hear a lot of anecdote, it comes to your point, Carolyn, about the kind of one-stop shop, is that we've got the same groups of patients having contact points across all of health and social care in lots of different settings. And one of the things that would be brilliant to be able to do is join all that together at patient level so that you can then inform individual services to say, well, actually, this patient is likely to be being seen in all these other settings as well, but from a real kind of evidence base, because there's a lot of anecdote, as I say. I'm just wondering whether you've made any progress on that joining up patient level data sets, because that's something that it feels like actually if we operating within restricted resources we need to look at. Thank you.
Yeah, so it's going to be a two-stage process. The first stage is for us to get the Barts data sorted. The second stage is to extend that data set to our colleagues in Homerton and BHRUT. And the third stage is to go to our other partners. And the way to do that is, I don't want to get technical, but is to use an SQL platform. So basically, what we need to set up is a shared SQL platform, and then we could pull the data down either using NHS number or using their MRN number. Now, I'm fully aware that within local authority or within different local authority in health, they'll have different NHS numbers. But what we could do is we could use a combination of postcode and date of birth. At least that narrows it down. Or use a postcode, date of birth, gender, and that actually narrows it down as further. So it's going to be a two to three stage process, and I anticipate if everything goes well, if we control the regulatory and legal framework within the next 18 months, we should have a one-stop shop within North East London. So I think the first stage is getting Homerton and BHRUT done. And once we've got that bit, then the rest of it should flow through as quickly as possible.
Great. So I think there's lots to be optimistic about. I think if you take that piece and combine it with some of the discussions we've had and heard today about the importance of SQL network training and the future skills of our finance staff, you can see there is a shift in our finance community and the skills that are needed going forward. And I think if you then combine it with the talk from Ed on sort of predictive analysis using AI, you can start seeing how some of this starts taking shape about how we manage healthcare going forward. and the important role that finance and our teams play in that. So thank you very much, Gerald and Carolyn. We're going to hand over to Emma and Nikki, who will come up on stage for the next session. But in the meantime, thank you very much, colleagues.